You're listening to Street Side, a Street Medicine Institute podcast.
Hello, this special episode of Street Side is a recording of the book launch webinar that took place on January 29th, 2026. The book being launched was the Street Mental Health Handbook, as written by psychiatrist Liz Frye and Simon Hatcher and psychiatric nurse Kim Van Herk. Liz Frye does street psychiatry in Pittsburgh and is the board chair of the Street Medicine Institute. Simon Hatcher and Kim Van Herk do street psychiatry in Ottawa. Here is the webinar. Welcome, everyone, to this dynamic and participatory book launch. We are living through treacherous times full of anguish and anxiety. As we straddle between despair and hope, we gather as a community of caregivers to reaffirm our steadfast solidarity with some of the most vulnerable and marginalized members of our human family. We celebrate the publication of this Street Mental Health Handbook and express our gratitude to Simon, Liz, and Kim for writing it. This book is a testimony that proclaims that trauma-informed, patient-led care that is acutely sensitive to the unique needs on the streets is possible. At its core, this book says to our unhoused neighbors, we see you, we hear you, and we are here for you in a spirit of loving kindness. Welcome to our three authors, Liz, Simon, and Kim. And our opening question is for you, Liz. Liz, what did you most enjoy about writing this book?
A big part of my reason for writing the book and a lot of what I've done in my career as a street psychiatrist is to try to help psychiatry or mental health not be such a black box for folks doing primary care, particularly folks doing primary care out on the streets, because they're certainly at the time that I started doing street psychiatry, there just weren't. There were a handful of us in the country, in the United States is the country I mean. There were all these friends that I had who were primary care providers asking me for brief consultations and what do I do with this and how do I treat that? And, after I told them to use a certain medication for a while, they all just started prescribing it to everyone. No, but I wanted to offer something that doesn't exist anywhere else, that would really be kind of a practical guide for primary care, but then also recognizing that folks who have who are mental health professionals really didn't get this kind of education in their training either. So the parts that were most fun, and I'll be clear that some of my chapters are maybe the most dense and difficult to get through, but I really enjoyed making all the tables and charts and things like that, because even as a psychiatry resident, nobody ever presented information to me in the way that I've put it in the book, where you can compare medications by side effect and you can think about what are the how do you dose it and how do you increase the dose and when do you call it quits and things like that. And so I didn't expect my primary care colleagues to know how to do that either. So I really enjoyed thinking about what is my process for doing a mental health assessment? How is it different on the street compared to in clinic? And then can I take that and put it on paper to make it more easy to follow for people who, hadn't had years of training in psychiatry.
This family provider needs to say, I was one of the first to buy the book, read the book, loved the book, and the chapters that each of you wrote are fantastic. But I want to stick with you, Liz. I want to ask you a bit about the Rapid Street Psych Assessment. That's something that we all are doing on the streets. Go a little deeper on that.
Sure. The Rapid Street Psych Assessment, I've been teaching for a number of years at various conferences and things. And it's what I developed for myself when I was out on the street in the context of working alongside a primary care provider, so that I would sort of keep pace with my primary care colleague, because they can do their visits a lot faster than a psychiatrist typically does. But then also keep pace with the streets, knowing that folks don't have a very lengthy attention span. They have other competing priorities. They need to check on their belongings. They may need to go, grab food from somebody who stops next to where we're providing care. They may need to go use while we're having a conversation if they start to go into withdrawal. So knowing that I would have a limited amount of time to accomplish a fairly lengthy evaluation, I wanted to figure out how to get to the bottom of like what was a good enough diagnosis and what could I prescribe based on that diagnosis in a safe way. And so those were kind of the two major questions I had for developing the rapid street psych assessment. And probably kind of one of the most important things in psychiatry is that you don't want to treat somebody with bipolar disorder or somebody with psychotic symptoms, such as schizophrenia, with an antidepressant by itself, because you can do more harm than good that way. So if I was going to get to the bottom of like what one medication did somebody need in like a 10 to 15 minute time frame, I really wanted to rule out psychosis and bipolar disorder first, because if I ruled those out, then I knew it was okay to prescribe an antidepressant. And like, I personally think that psychosis is like one of the easier things to diagnose. You can use your own observational skills, and you can also just ask people, like, do you hear and see things that maybe, or have experiences that maybe others around you don't have, or you wonder about it. And bipolar disorder is a bit more complex, and there's some complexity into sort of separating out, like I do a lot of undiagnosing of bipolar disorder and re-diagnosing with PTSD. But just kind of, I wanted to give sort of a decision tree that would flow relatively easily for making decisions in 10 to 15 minutes of what is the single medication that I can most safely prescribe.
Well done. Well done. The rapid street psych assessment is incredibly useful, worth the price of the book in and of itself. Simon, Liz just mentioned PTSD, and you mentioned trauma being one of the main tenets of this book. Trauma and chronic PTSD are almost universal among rough sleepers, and you have written about trauma as both a risk factor and consequence of homelessness, and you have broadened the lens that trauma is not just individual, but also collective, historical, and structural. Can you say a bit about useful approaches to addressing trauma in street medicine practice?
So nearly everybody I see will tell me a story about having a really difficult start in life, and that's often around suffering neglect or abuse of various sorts from the people they grew up with, who are often their family. So what people learn is that people who care for them hurt them. So when I come up to somebody and say, hey, I'm going to look after you, that's actually a really scary thing to hear for a lot of people. And they'll literally run across the street to avoid me or not come and see me at all. I think one of the core skills of street medicine is getting around that somehow and realizing what an important dynamic that is and how to manage it and how to gain trust and to earn trust, I think is probably a better way of putting it, both in yourself and the organization that you work with. And a large part of that is doing what you say you're going to do, turning up and doing what's necessary. In many ways, that's one of the taglines of our organization is we do what's necessary. The other day, I was doing wound care on somebody. I'm a psychiatrist. What am I doing? Touching people? I mean, for goodness sake. But I was doing wound care. And the important thing is not that I was doing wound care, but that the guy I was seeing trusted me enough to do it. And it's what needed doing at that moment. It was the mental health bit of persuading him to take his bandages off, which is the important bit. The wound care was just the technical piece, if you know what I mean. That for me is one of the core skills in street medicine, is that overcoming or being aware of that core dynamic between you and potential clients and how you manage to overcome that.
Relationship and rapport can be therapeutic, I think, as well.
Relationships, psychiatry, it's so important. And it's one of the things that you can do with street medicine because of the flexibility it gives you to be creative about forming and holding relationships.
Yeah. Thank you, Simon. I have one more question before we get to the Q&A, and that's for you, Kim. I loved your chapter about the inherent chaos of doing street medicine. There's a whole chapter on chaos, which I really enjoyed. Can you say a bit about how to manage the chaos, both for ourselves and for our teams?
I can't help but laugh because we started this podcast and I had my team helping set up the food here because I was in chaos from our day. So I guess teamwork is a big part of managing the chaos in that, sometimes you have to ask for help. The strength of, sometimes at the end of the day, looking at your team and knowing like you did those things together. Sometimes sometimes your team members have no idea what you've been through in a day, but they tell a dark joke and you're like, okay, like we've still got this. But I do think team is really important. On a personal level, to keep managing the chaos, I think you do have to figure out how to take care of yourself. So like there is the team care and the community care are really big components. As an organization, as teams doing the work, you have to figure out how as a team do we take care of each other, and thinking about that can look like so many different things. And I think talking with different street organizations and street teams the shelters, outreach teams, we're all trying to figure out how to do this better as organizations. And so I think that there's still so much work to be done. I think, and I struggle with the whole self-care piece because I don't want to be like, oh, just go take a bubble bath and it'll be fine. Because I also like fundamentally don't believe in that, but I have had to learn the things I need to do for myself to keep myself well, because frankly there are times where you do look at yourself in the mirror and think, am I losing it? Like I have had those moments of that. I do think you have to dig in to figure out what those tools are. There's, of course, exercise and food and sleep. And if those things aren't happening, the other thing is really important. It's like you have to have a life outside of this work. Sometimes the work is big. It takes up a lot of space. It takes up a lot of emotional space where people, I see people that start to lose relationships or start to say, I have so much energy I've put into my clients that I'm not putting that energy into my other personal relationships. And like, that's a big warning sign, right? Like, this can't be your whole life. And so figuring out how to manage that energy and what things you're putting into yourself that are renewing your energy. And I mean, that looks different for everybody. But again, where I think that the team and that aspect is really important, because I do think about the little things like hugs and laughter and sharing lunch together. The other day, a bunch of nurses were like talking about family members that we were dealing with of clients, which, I mean, on one hand is a blessing because that doesn't happen very much. But on the other hand, it was really helpful to just like look around the table and be like, oh yeah, like this shit is complex out here. So yeah, the sense of when we get really isolated and feel like we're the only ones dealing with really hard things, like that's also a very slippery slope.
Thank you, Kim. And I think that's one of the things we all love most about the International Street Medicine Symposium, ISMS, that the solidarity, that we're with the extended family, people that understand us. Like, sometimes family and friends wonder what the heck we're doing on the streets. And, and it's just nice to be in solidarity with our colleagues. We're going to move to the Q&A now. And Liz, this question is going to be for you. Morgantown is asking, does the book address untangling misdiagnosed bipolar versus PTSD? Can you speak more to untangle this from chaos, minimal literacy, or other unrecognized mental health conditions?
Yeah, so that is the work of street medicine, right? We're trying to untangle all of that. Yes, the book addresses it. I think a lot of what I work to address is untangling kind of the chicken and the egg components of things, and like untangling the what are the mental health symptoms in relationship to the substance use, because I find a lot of street medicine folks asking me like, well, what of this is like caused by the substance use and what of it isn't. And then also like untangling some of the different diagnoses with each other. So this is where again, like, it's super nerdy. And I made a Venn diagram for some of that. So it's like,
Good for you.
so, like, comparing symptoms of mania to those of ADHD to those of PTSD, because there's a lot of overlap there. I think to some extent it's helpful to know if some symptoms predated other symptoms or events in a person's life, or, did somebody have a period of sleeping inside for a couple of years where they had a more stable environment, and what symptoms persisted versus what didn't change with those symptoms, or what if they were incarcerated for a period of time and maybe they couldn't access the drugs that they usually do. Now, we all know that people can access drugs in jail and in prison, but sometimes people aren't able to. So, like, trying to think about when are the times that we know some of those factors weren't a problem, and looking at what you're left with is kind of what I try to do.
Yeah. Thank you, Liz. And there's a quick question from Wendy here. Is there any talk of getting this book out in French or Spanish or other languages? Has
We
that
were just
happened yet?
happy to get the book out.
You're happy with the English version so far.
Yeah, you're lucky you got a half literate English version, but
Yeah, right. Okay.
The answer is not yet.
The answer is not yet. Okay.
I
An
like
audio
the-
version, an audio version would be up there too.
I like
I would-
the way you're thinking, though. I like the way you're thinking. All right.
We're
All
gonna
right.
have Simon read the audio version.
Shit, you don't want that. You don't want that.
All right.
As a professor of psychiatry, I can say these sort of things, but diagnosis isn't that important in psychiatry. It doesn't often tell you much about what to do, and it particularly doesn't tell you anything about meaning. One of the first things I noticed when I started working in street medicine is that working in hospitals, people come to you and say, I've got these horrible symptoms, take them away. But working in street medicine, it's almost like that's not the priority at times. It's, I've got these horrible symptoms. Why? What does it mean? And often the conversations I was having was trying to come to some understanding of why people ended up at this particular stage in their life at this particular moment. In many ways, that often seemed more important than the particular diagnosis. That's one of the reasons why I quite like the idea around trauma-informed care and its tagline of it's not what's wrong with you, it's what's happened to you, which is important.
Yeah. Simon, let's stay with you for Jay Levy's question. He's wondering about the relationship, person-centered work that needs to be done pre-treatment. How does that fit into the work, including the building of a common language around treatment of mental illness?
Well, I think the relationships are the treatment, and not necessarily even pre-treatment. And the prescribing medication is important. You can't downplay the effect of medication, but also it has symbolic value as a measure of care at times. I find red pills are particularly good, but seriously, the relationships are the job, really. If you can maintain a consistent relationship and endure rupture and repair, because that's when change happens. When relationships go bad, and then you repair them. It's like in a marriage, Nobody expects a marriage to be no fights, no nothing, but it's surviving those times, coming to an agreement, getting past it is what counts. It is something that often people haven't experienced before, where conflict is often results in rejection.
I want to cut in here as the nurse to Simon's doctor, because I do think that it's important, often there are people that are building relationships with our people on the streets before doctors get to see them. It depends on your model, but at least here in Ottawa, like us nurses, our peer workers, shelter-based workers, there's a bunch of people. So one of the things that, and I think to say that sometimes that takes a really long time. And sometimes it's really important that it gets reflected to the psychiatrist how long that relationship has taken to build. Because sometimes Simon is sometimes looking at me like, Kim, what do you want me to do in this? Because sometimes people expect the doctor to walk in and make the grand diagnosis. But if it's taken me like a year to build rapport with somebody and I'm like introducing this person, like I have to be very clear with Simon of like, it's taken me a long time and we got to take this slow. And sometimes it's really annoying, and they're like right away open up to him, and I'm like, for Pete's sake, like, you have no idea what I put into this. And then he laughs at me. But like I do think it's important also from a team-based perspective of being respectful of what other people have had to put in to make that relationship work. Because and then that thing of, Simon does a lot of work because he meets people on the street, but those people often go then into our supportive housing. Sometimes we have a guy right now that we're working with that is becoming closer and closer to end of life. And Simon has worked with him for a long time. That Simon's one of the people, even for the medical team, that, when they're talking around end of life stuff, it's Simon he wants to talk with about his congestive heart failure because of that relationship. So
yeah, relationships provide information, but they're also a therapeutic tool.
Yeah, it's everything. Yeah.
I think we can all agree that individualism is one of the scourges, and the social relational poverty of people on the street is one of the things we're combating. Mercedes Martinez from Chicago is saying, "Hola, are there any bicultural and bilingual psychiatrists that are involved in street psychiatry, and have they written any books? Anybody know? Has that happened?"
I don't think anybody has written a book about street mental health other than us. I think, well, I don't know how much French you speak, Kim. I think maybe Simon speaks the most French of all of us. Is that correct? So that's about as far as the bilingual component goes. But yeah, I think it's really encouraging that over the 15 years of doing street medicine, I have seen the interest in street mental health care just expand enormously. And a lot of that interest is coming from students and residents and other trainees. And that group of people is far more diverse than the white people with privilege who were given who were sort of trusted enough by the people with the money to start these programs. I think that's the white male privilege is a big part of how kind of street medicine got started. And as time has gone along and shown that street medicine work is a really critical and effective component of working with people out in the street, you see more women being able to start and lead teams. And I think we're seeing far more people of a variety of races and ethnicities and cultural backgrounds and genders, et cetera, to be able to lead this kind of work. So it gives me a lot of hope for the future of what's out there, and that it's not just left up to the three of us.
I mean, your book is groundbreaking, and we're hoping for more ground to be broken. Rebecca is asking about group therapy. She's hoping to do some mindfulness combined with CBT in a group with people with chronic pain. But is this something that is happening on the streets? Is anyone aware of group therapy as opposed to individual therapy?
The trouble with groups, whether you do them on the streets or not, is getting people to turn up. And it's almost like if they turn up, they're cured.
Yeah,
because the motivation turn up. But I mean, yeah, if you can get it done, great. We don't do any formal group therapy. Maybe we should, but we haven't. We do see people in groups. In some of the supported housing units, they have some group-based activities, and that's about the closest I think we get to it.
There is a psychiatrist. Sorry, I'll just say this real quick. There is a psychiatrist in New Haven, Connecticut. Her name is Emma Lowe, and she was piloting some group therapy, I want to say, for women living on the street who are sex workers, and I think had a fair amount of success with that. It was, and the success I think from it was that it was so driven by the people who participated in that group that she did really good work to figure out what kind of meetings make the most sense and where would a meeting be easiest for you to attend? Where would you feel safe? Who would you want to be in that space in addition to you? And so it was very, very street based and led by the people who were seeking the treatment. But I don't know. She would be a better person to speak to, like, how she's done it.
You're teeing me up, Liz.
Okay.
I'm interviewing Emma Lowe on Monday.
Okay.
Street psychiatry in New Haven. She's at Yale. And so stay tuned. She'll be on a Street Side podcast soon, and we're going to delve into those questions. Carson has a question. How do you balance the desire to help people with the potential to pathologize and stigmatize through psychiatry? How does the balance influence the way you approach people and frame mental health? Who wants to take that one?
Sorry, can you repeat it so I can digest it a little more?
Yeah. So diagnosing, the danger is pathologizing and stigmatizing through psychiatry. And how does this balance influence the way you approach people and frame mental health? So my understanding of the question is, by giving somebody a label, you're schizophrenic, that's got implications, and pathologies, that are we tend to pathologize the individuals when sometimes, especially with the PTSD, people are victims of larger forces. But I guess Carson is asking how to balance, diagnosis and treating people with not stigmatizing and pathologizing.
I think that is the slowness part. And why the approach is different. This isn't where somebody is coming into your office and looking for help. Like if you are, when I think about walking around the shelters and seeing people I want to help who have no insight into their mental health, for me, it's really the only way to do that is based on the relationship. So if I'm hoping to help them, because I can see them obviously responding to their voices, the things I'm doing are what are actually the things they want help with, because it's usually around meeting basic needs. Lots of time, I'm starting off with food, clothing, sometimes a good I really love putting people's feet in water and trapping them with me and then putting lotion on them because often their skin is in such bad shape. So there are some times where people come to you and they're, very ready for a diagnosis, but most of the time people aren't. And again, we have to think about where people's priorities are, that if people are in survivor mode, that, being told another label isn't really helpful to them. So like sometimes we don't really even talk about the label. We talk about the things that people are looking for help with. Sleep. Okay, we might see and think in our head about the things, I'm worried that this sleep issue is about trauma. Or I'm worried it's about the voices. As professionals, there's lots of things we're seeing or naming inside of ourselves that we're not saying out loud to that person. But I do know, the different medications and the things that they help with. And so when I'm offering treatment, I'm thinking of in my head, okay, well, this is going to help you with your thoughts and it'll help you with your sleep, and so I'm not saying this is going to help you with your schizophrenia. I'm saying this is going to help you with the thing you're saying you need help with. So that would be really, and the trauma one is one to be really sensitive about, because, if you've had all these bad things happen, like sometimes people are like, oh, like, I don't need a label. Like, we don't need to make people feel like we want to empower people. So it is about, that these awful things happen to you. We know the science tells us that if you experience adverse childhood events, that your brain actually changes as a child. That makes you more so it is really about taking the blame and the shame off people. That's in some ways our job as street mental health professionals. Is this isn't about you being a bad person or something being wrong with you. This is about what the system has done. This is about genetics, but I think,
the other teachable skill.
Can you pull the microphone over, Simon?
So the other teachable skill for medical students or residents is to put the strong feeling into words. So something along the lines of what my worry is that you've had really bad experiences in the past with healthcare, with mental health care, and I really worry that what I really don't want to do is to re-traumatize you, and just putting that into words often helps to neutralize it.
Yeah, thank you for that. I think one of the most profound things I've heard about street medicine is it's not patient-centered care, it's patient-led care. And you're all talking about that the patients are in the driver's seat and we're responding to what their needs as they articulate them. There's another question from Amy in the Q&A for any of you, or Liz is going to answer this. Roles for trained LCSW volunteers in mental health street medicine. What do you, Liz?
Yeah, so I think the volunteer part really depends on whether there's an existing street medicine program in your community, and you would have to look kind of locally to discover that. We at the Street Medicine Institute are also working on a map of street medicine programs, so you may at some point, hopefully in the not too distant future, be able to look and see on a map if there's a street medicine program in your community. I think more than anything, licensed like mental health social workers, licensed professional counselors, so not a prescriber, but who can make a mental health diagnosis, are oftentimes highly sought out for street medicine programs. It is more, and I think it's because those folks are not nearly as expensive as a psychiatrist or even a psychologist. You're able to make a diagnosis and you're able to provide ideally some therapy for folks on the street and kind of act as a consultative role either to a consulting psychiatrist or to kind of help out when primary care is like, I don't know what to do now. And so, you know, if you love your job and you want to do that and you just want to volunteer, I think there'd be plenty of people who would be happy to have your services. If you want to quit your job and become a street mental health clinician, I think you'd probably have people, you know, biting at the bit to hire you.
Great, thank you, Liz. Jeannie Aycock is asking you, Liz, to spend a little more time on the rapid assessment tool. And I'm gonna suggest to Jeannie, buy the book. It's a great book, and the assessment tool is done in great detail. But if you want to take a couple minutes here, Liz, and just walk us through that tool a little deeper.
Well, so also for the record, Jeannie Aycock is my mother. So she actually knows more about it in detail.
Yeah, she's
but
teeing
for
you up.
those of you interested in, Mom, I can like sit down with you and go through it. No, I'm joking. For those of you who are interested in kind of a more detailed deep dive into making a diagnosis and using that rapid street psych assessment, I am going to be doing an echo session in February. I think it's February 9th. And yeah, she does have the book too. So Project Echo is something that originated through University of New Mexico. And they have echoes about all kinds of things. But we were able to start a street medicine echo as a collaboration between the Street Medicine Institute and the street medicine team at University of New Mexico. And drawing on the resources of Project Echo. And so for the February, I like I said, I think it is on February 9th. I'll be talking all about making a rapid street diagnosis. If you're interested, if you don't know how to get to that echo, you can Google Street Medicine Echo. You can also go to the Street Medicine Institute website and click on the echo section there, and it'll take you over to where to register for echo. And then you can also, once you've like registered, you can also watch all of the video recordings of the echo sessions that we've done in the past little over 2 years, including one that I did about ADHD treatment and one that I did about psychosis treatment on the street.
I have a question for you, Simon. On page 141, chapter you wrote, I loved when this I wish, I worry, I wonder. Tell us a little bit about how you utilize that.
I will, but I'll use Kim's voice. Do you want to
did Kim? Okay, Kim going to tell us?
Yeah,
I found that really, I found that really useful.
No,
I thought that was your chapter, Simon.
It is my chapter, but we all contributed to each other's chapter. And it's an idea from palliative care that Kim introduced me to. To explain it a bit more?
Yeah, there is a tool. It's the oh my gosh, the critical conversations toolkit, and so that's really where I got it from. I can't take any credit for it. But I find it helpful for all sorts of things, like all sorts of different conversations. So talking, yeah, it's from palliative care, but talking about mental health, the things that when you're trying to talk with people about treatment, the things of like, the things that we hope for people. And sometimes it's the things of like, I wish you didn't have to take meds. Also, like, I'm with you. I wish that this wasn't a thing that you had to bother with. I worry if you don't take your medications, you're gonna end up back in the hospital again. And like, I wonder if you just kept doing this for a little bit, what could we do what supports could I put in place? What could we put in place to help you be able to do this for a little bit longer? So yeah, it's a really helpful tool for talking about all sorts of difficult things.
Yeah, I've been using it, Kim. I wanted to jump in. Ever since I read it, I've been on the streets. I'm like, gosh, I wish you weren't struggling so much with your fentanyl use. And I worry that you're going to overdose. And I wonder if you'd like to try some buprenorphine. Just it's a simple boom, boom, boom. I wish, I worry, I wonder. I find it to be a very effective tool.
And of course, again, it's a relationship tool, because putting I there means that you own the feelings. You don't have to put it onto anybody else. You own the feelings, you own the thoughts. They can't argue with it because it's your worries.
Yeah.
Yeah.
Right.
Yeah.
Yeah. Let's go back to the Q&A. There's a question from Johanna Brown. What risks threaten the long-term legitimacy of street-based care? I mean, threats to long-term legitimacy. I wonder about the word legitimacy. What long-term survival of street-based care, like, Medicaid, does anybody want to talk about the macro level threats to our street medicine burgeoning movement? I consider this a movement. This is from the grassroots, and what are the threats? Liz, you might be the best person to answer.
Yeah, so I can speak to that broadly, but then also specifically to the United States. And I'm sure Kim and Simon could see something, in terms of policy in Canada. There are a few things that are sort of universal threats that those of us who've been doing street medicine for a while have encountered. There is always sort of, I think what Jim Withers, the founder of the Street Medicine Institute, calls retreat from the streets. And so it's either street medicine teams ending up kind of going back into clinic because of whatever reason that may be driven by the team, or it might be that people are pulled back from the streets by their bosses or administrators or whoever. And I was actually having a conversation about this morning with some folks, particularly like the more expensive you are to a street medicine team, like the higher your salary, the more you have to justify your reason for being out on the street. And so a lot of times that's the physician or the advanced practice provider. And the articulation of like why it's so important, I think, was specifically kind of addresses what Kim was saying about like, I've been working with this person for a year and then I have to get that person to trust Simon. Well, it's a lot harder to get that person to trust Simon if Simon comes to the streets than it is to drag that person into a clinic, which is our space that is traumatizing to that person, and then trust Simon, right? And I think also we have a better chance of Simon himself being able to make trusting relationships with folks on the street without having to do any of that trust grafting from Kim to Simon, in which there might be graft rejection, right? So I think that's one kind of universal thing, is that we're always having to justify why we should be out on the streets. in the United States in particular, there have been a lot of changes in the past year. I think changes with Medicaid, for example, are a huge one, where people have to, there are a number of new requirements in order for people to be able to keep their Medicaid. And people who are sleeping outside, I think, are particularly vulnerable to losing their Medicaid, because it requires proving that they have a disability that would mean that they get a waiver for work or volunteer stuff, but there are only certain things accepted. So it's not like I, as a street medicine team member, can write a letter and say, so and so, Bob should not have to work because Bob has X, Y, and Z problems and whatever. That's not an acceptable way to say that Bob shouldn't lose his Medicaid because he's not working. And then there's certain diagnoses that would indicate that a person doesn't have to fulfill those work requirements. But a lot of folks who we're seeing out on the street have never gotten care anywhere before. And so they may not have a history of those diagnoses, or maybe the street medicine organization that's taking care of them doesn't bill Medicaid. And so there isn't that track record of them having a diagnosis that would exempt them. And then the practical things of not having an address or a phone number and things like that.
Thank you, Liz. I think we are running out of time. In the chat, there is the link to purchase the book. I want to thank our authors, Liz and Simon and Kim. Thank you for this delightful hour of talking about your work, your book, and this has been a successful launch.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.